Good morning, my dear students. We are here to discuss the anesthesia recall questions that came in the FMG exam this time. And as you all know, anesthesia is always a very easy subject that comes in your exams. And so we got three questions, and all three of them were very, very easy. So let's start with the first one. This is more of a logic-based question. Before laparoscopic surgery, what advice would the patient be given by the surgeon? Now, this is something that is a part of surgery as well as anesthesia. So, surgery faculty might always also teach you this. NPO of 8 to 12 hours before OT, NPO of 24 hours before OT, on-table hair removal by laser, and none of the above. The correct answer to this question is none of the above. Now, one might get inclined to mark this 8 to 12 hours before OT, which originally would have been a better advice, where we say that keep the patient NBM after 12 midnight or after last meal or after dinner. But ASA, which is American Society of Anesthesiologists, have given a very specific fasting guidelines, and that depends on the type of the food that the patient has taken pre-operatively. So depending on the type of food, the level of NPO or nil per oral or NBM or nil by mouth will keep on changing. So suppose the patient has taken a full meal. How do you define a full meal? That contains fat or meat, that is the normal food that we have, dinner, lunch. Then you need to fast for 8 hours. If somebody has light meal, say toast bread with a cup of tea, then 6 hours. Now, light meal or non-human milk. So in pediatric patient, if somebody has given non-human milk or formula feed, all of these would be 6 hours. What if somebody has taken breast milk? This is only applicable for infants. Breast milk, then it has 4 hours. And finally, clear liquids would be 2 hours, right? So if you say that somebody who is going to undergo a laparoscopic surgery should be blanketly made NPO for 8 to 12 hours, then that is a wrong statement. NPO for 24 hours. So prolonged fasting has now been stopped. There is no use of that prolonged fasting. It actually decreases it increases the morbidity after the surgery. It improves, it doesn't, it actually causes the patient more problem than it accepts or prevents the incidence of aspiration, right? So this is definitely wrong. Now, on-table hair removal, now this is something of a gray area. See, you normally do on-table hair removal because one would feel that, okay, there are a lot of hair and stuff like that, but multiple studies have confirmed that there is no difference between the incidence of surgical site infection between somebody who has been shaven or non-shaven. Now, there are different ways of removing the hair: razor, clippers. Clippers are always preferred over razors, because when you put a razor, then you cause micro abrasions that acts as a nidus for infection. So on-table hair removal by razor is wrong. It should be by a clipper. If at all you want to remove, it should be by a clipper. So this is correctly the wrong option. So the correct answer is none of the above. None of the above advices are correct. Okay. Next is, you were somewhere and you saw a guy collapse. Okay, so this is a case of CPR. Very good. You start CPR after checking vitals. Okay, so you know that it is a cardiac arrest, and soon advanced cardiac life support arrives. What is the next step you will do? Again, something of a logic. Hand over the patient and leave. Ask them to apply the paddles while you continue CPR. Stop CPR and let them apply the paddles. Continue one round of CPR and then use defibrillator. So now what is happening here? When you saw some guy who has collapsed and you started CPR, you were doing BLS. In BLS, what a patient does is they do chest compressions, and whatever help you would have called would get an AED, so you can use an AED. But at the same time, you call for help and you inform the ACLS team to come. Now, ACLS is a team of advanced cardiac life support, which comprises of members that are well trained, and they come with their own equipment. So they will bring a manual defibrillator where they will analyze the rhythm themselves. So once you are doing BLS, you can only use AED, but once the ACLS team comes, then they will start using manual defibrillator. So what you will simply do is you will hand over the patient to them. They will apply the manual defibrillator. they will check the rhythm, and then they will see whether it has to be shocked or not. So that is their decision. That is not your decision. You cannot simply tell them, okay, I'm continuing CPR, you come and apply the paddles. Okay. They usually come in a team. They will take over the whole of CPR. Somebody would come take over the compressions. Somebody would come and start applying the paddles. So it's better to hand over the patient and you can then leave because your job is done. Okay. Ask them to apply the paddles while you continue CPR. Sounds logical, but then again it's the same thing. Somebody will take over the CPR, somebody will take over the chest compressions from you, and somebody will start applying the paddles. So this doesn't really sound that correct. Stop CPR, never stop CPR to let them apply the paddles. Okay, and continue one round of CPR and use defibrillator also. Again, something that should not be done. Okay, so the correct answer is hand over the patient and then you can leave. You can see here, the moment an ACLS team arrives, they start CPR, they give oxygen, they attach monitor. So they take over the whole process from you. Okay. Analyze the rhythm. If it is shockable, give shock. If it is non-shockable, give epinephrine and continue CPR. Right. So this is the ACLS algorithm. The moment an ACLS team arrives, they will take over the resuscitation from you because your job as a BLS provider is done. Okay. Which of the following inhalational anesthetic agent uses special vaporizer? Now, this is something that I teach in almost every class. Desflurane. Why? Because of special physical properties of desflurane, which is a very high vapor pressure, 660 mmHg, and very low boiling point of 23.5 degrees Celsius, right? So what happens is at room temperature, which is usually more than 23 degrees Celsius, desflurane is in vapor form. And that vapor also has very high pressure, 660 mmHg. So you cannot contain it in a small form, which is the liquid form. Therefore, you cannot deliver it precisely. And then you need to use a special vaporizer called as Tech 6, which is a gas vapor blender. So because it cannot be given by a conventional vaporizer, therefore you use a special vaporizer called as Tech 6, which is a gas vapor blender. These are the 4 points that you have to remember in desflurane vaporizer, because this is what they ask. They do not go beyond this point, because description of a gas vapor blender or a Tech 6 vaporizer takes hours to teach. It's a very complex phenomena, right? So these are the 4 points that you have to remember. Desflurane needs special vaporizer because of unique physical property of high vapor pressure, low boiling point, and the name of vaporizer is Tech 6 and the description is gas vapor blender. All right. So these were the 3 very, very easy questions that came in anesthesia and FMG exam. I hope you are revising your notes properly and everything is coming from the notes that we give you. So all the very best and keep working hard. God bless you.